everyone see my presentation now?
I can.
Good.
Okay, so I'm going to talk a little bit about the lifespan model in Toronto, which is a partnership of Toronto Rehab Institute, which is part of the University Health Network, and Holland-Bloorview Kids Rehabilitation Hospital, which is a children's treatment rehab hospital in Toronto. I'm going to go through a whole bunch of slides fairly quickly, and hopefully we'll have some time at the end if anyone has any questions. So what I'm going to talk a little bit about is just the development and implementation of the model itself. A research study that we have aligned with the lifespan model called the LET study. I'll talk a little bit about some of our successes and challenges and what we would like to do next. So as I mentioned, it's a linked model of transition between a pediatric center and an adult rehab hospital. And we're very fortunate to be very closely located. So it's really just about 100 meters away. Both sites are really close together, just a parking lot in between them. And it was developed with that kind of purpose in mind, being able to locate the adult service close to the pediatric center so that it didn't seem so far away and foreign. We are also fortunate to have a few staff who are jointly appointed to both centers. So we have a nurse practitioner, a youth facilitator, and I'll talk a little bit more about that position later on, and a life skills facilitator who actually work in both the adult center and the pediatric center. Some of the sort of foundational components to the model are shared management, and I'll talk a little bit about that. A real emphasis on life skills opportunities, and a chronic care model. So this slide sort of depicts the basic structure of the model. So we start, the intention is to start early in the pediatric care with Growing Up Ready was developed here at Holland-Bloorview and is a framework for preparing people for growing up, as it would indicate. And then there's some specific activity that happens later in adolescence, in preparation for transfer, and then a move to adult services. This is a different depiction, just sort of showing that the emphasis in early years is around the Growing Up Ready framework, and then between 16 and 18, we have sort of an increased emphasis on preparation for transfer to adult life and adult services, and that, depending on the needs of the young person, can be more of an emphasis around preparing family or preparing the young person themselves, or a combination of both. There's actually a transfer service for our young adults with CP, cerebral palsy, where our ABI group is more followed by the same right through to their 18th year, and then they transition to Toronto Rehab at 18. So I mentioned before the timetable for growing up, and there's a picture there on the side of the framework. So it's developed around 2005, actually, so actually before I started working with Lifespan and before Lifespan existed. And the idea is that it's a gradual progression of skill development. And there's some, in this timetable, there's indication of where age-appropriate times, but also there's a lot of tools that don't really have any age associated with them, so it's more as the person is developmentally ready to move along. But you'll see it's on the left-hand side. It looks at not just sort of medical and health-related issues, but also education, self-care, and social and parenting are also components of it. And it's very small, you can't really read it, but as you move along towards the older ages, the text shifts to be more focused on addressing the young person themselves, whereas the early years is really directed more towards parents. in association with that, the timetable for Growing Up Ready, we also have a series of checklists called the Growing Up Ready checklist. And these are getting started, on my way, and almost there. And they're, as I said, checklists that help the young person to identify some goals around preparing for additional responsibilities or moving along the spectrum, and they can work on these themselves and they can take them home. The idea is that these are tools that the child and the family, or the young person and the family can use. And these are all accessible on the Holland Bloorview website. You can download them as PDFs, I believe, or if you like the sort of more solid versions, you can actually order them from Holland Bloorview. So as I said, one of the sort of foundational components of the model is shared management, which Keith Pepper and Franz are the two authors, and it's really speaking to the alliance between the young person and the family and the service providers, allowing the young person and family to develop independence and take more responsibility for their care as they grow up. And a definite movement sort of away from the care providers having all of the information and all of the knowledge to allowing the child, the young person, their family, as appropriate, to have that knowledge and skill. Another key foundational component of our model is life skills opportunities, and really the principle there is that any opportunity in life is an opportunity for growth and education, and actually doing things in the real world gives opportunity for problem solving and life skills development. So in that experiential learning is really an important thing to be able to do, and often young people with disabilities don't have quite the same opportunity for this experiential learning as some of their peers do. And it really involves taking some calculated risks and doing things where you may fail or may need to do it more than once to succeed, but doing it in a safe environment to promote problem-solving skills and confidence. And just as I said, so any encounter can become an opportunity for skill building, and a lot of our programming is based around that, engagement of the young person in activities and developing skills through those encounters. One of the other key foundational elements of when we were developing the lifespan model was the chronic care model by Wagner, and the points on the screen there indicate sort of the key components. But really, when you look at adult rehabilitation services, it's really a significant change in practice, or in traditional practice, where adult rehab tended most often to be management sort of acute issues, such as a hip replacement or a stroke, rather than a chronic care model. So we're different than a lot of the other health services at Toronto Heat Rehab. There are others that are sort of developing similarly, but I think at the time when we first started in 2006, it was a fairly novel approach. And it certainly involves improved client self-management, planned visits over time to address prevention, health promotion, strong links with the community and involvement of family practitioners in the care, care coordination, development of expertise in all the levels of care, but also in the young person and their family, capacity building, and the importance of improving primary care for people with chronic disabilities. When we look at the actual adult services as part of Lifespan, usually our first appointment is around 6 to 9 months after they've been discharged from pediatric care, and that's an intentional gap because we're not going to see them really often, and it's not a model where we're having intense ongoing therapy or involvement. So that sort of 6 to 9 months is follows their sort of care and their intervention patterns when they're in pediatric care, and gives them a chance to be an adult and be in the adult system and consider what they're going to need. On their first visit to the adult service, they're given we use an initial assessment document that allows the young person and their caregivers, if they come with caregivers, to look at what they would like to address in their visit. So it's been designed in partnership with some speech-language pathologists, so we have visual as well as verbal descriptions of typical goal areas, whether that be around health management or diet or life skills or independent living skills or managing money, all these, and then the sort of pictorial components beside it, and they can identify what they'd like to work on. A big focus of our service, because we have a lot of clients and not a very big team, is ensuring that we're linking them appropriately with community service and specialists. We're not going to be able to provide all those services ourselves necessarily, and we've developed a number of group treatment options to address sort of some of the typical things that come up with our young adult population. And some of those groups I've listed there. The Moving Out Boot Camp is a 7-week program run in the evenings with our young adults who have an interest in moving out. So typically our young adult clients are living with family often, so it's sort of an exploratory group that looks at some of the skills you would need to live independently. There's a sort of a follow-up group that they can do through Holland Bloorview's participation and inclusion called the Independence Program, which is actually a residential program where they stay for 3 weeks in university residence in the city and can practice in much greater intensity around specific skills. But Moving Out Boot Camp is kind of an introduction to independent living, and there is a parent component to that as well. So our social worker meets with parents at the beginning of the group and towards the end, just addressing some of their concerns around their child moving out and becoming more independent, and how they can develop some of those skills with them or work with them towards that goal. My Health is a group, I think it's an 8-week group, and we also run that one in the evenings, and it's more around knowledge of disability, knowledge of your health care needs, advocating within the healthcare system, and ensuring connectivity within the healthcare system, as well as some health promotion components. Outsmarting the Pain is a workshop that we ran specifically for young adults with cerebral palsy that were experiencing some chronic pain. So it's a 1-day workshop. And Fitness in the City is we've just actually run for the first time this past summer, which is a group run by our physio and one other team member, looking at how to access fitness programs within Toronto. So looking for accessible programs, looking for programs that can meet your needs, and how you research them, how you use some of the equipment, and how you might engage some of the staff in those centers towards improving your ability to stay fit and healthy without health care. Some of our future plans are with our youth facilitators is developing a sort of a social group, and we're thinking that that's probably going to be a drop-in group, and we're looking to start that in January, but we're still working on some of the details. We're also looking at developing a stress management group, and we do have actually a chronic care, what's it called? It's called self-management group that 2 of our providers have done some training around the self-management program, and they're going to run that this fall as well. We're also looking at partnering with other agencies to deliver some groups. There's a group called Flexibility that's run out of the Ann Johnson Health Station here in Toronto that we're looking to link with. And one of the areas where we see a gap is around, we have a lot of young people who are very interested in developing skills for work, or either paid employment or for volunteer opportunities, and we're finding that that's a bit of a gap. So we're looking at who we can partner with to do some work around developing skills for job readiness. There we go. One of the roles I mentioned on our team is called a youth facilitator, and this is actually a young adult who has grown up with a childhood onset disability. and someone who successfully transitioned to adult life. And they're actually part of our healthcare team, so both in our pediatric team as well as our adult team, and they're cross-appointed. One of them is in Evan England as well. He just works with our adult team. And it's a fairly unique role, we think, in that it was really reflects a commitment to including the client-family perspective into our model of service. And they're not a volunteer. They're really we wanted to make sure that it was really valued as a member of our team, and so it was a paid position. And it really can be a valuable and I think a very powerful position in terms of promoting some positive change within our young adult population, acting as a role model, but also sharing their own personal experiences. And sometimes it's things as simple as where might I go out for dinner on a date that has an accessible washroom, or where how do you approach an interview in terms of what do you share about your disability prior to an interview or in the process of applying for a position, and things like that that are really valuable. It's been a really powerful position, and I can say from firsthand experience seeing the young adult meet with our youth facilitator, that's incredibly powerful and definitely something that I would recommend other organizations look to do if they don't have that already. I'm having trouble moving my slides. Here we go. So the next thing I wanted to talk a little bit about was our LET study, which is the Longitudinal Evaluation of Transition Services, which is a joint research project between the Bloorview, actually the Bloorview Research Institute and our Research Institute at Toronto Rehab, and it was funded in 2008 by the Ontario Neurotrauma Foundation. So it looks, one of the things that there's certainly a gap in the literature around the effectiveness of different transition models and models of transition services. So we wanted to establish an evaluation structure as we were rolling out our model. So the primary outcome that we are looking at is continuity of care. So does the young person remain linked within the healthcare system? Are we successfully transitioning them and not losing them? And secondary outcomes will improve healthcare, improve participation, quality of life, satisfaction with services, and things like that. So it's a 4-year study, and we're actually nearing the end of our 4 years. The first couple of years have really focused more on the process because we didn't have enough time. We didn't have the clients in our service long enough to really look at outcomes. So the process parts looked a lot at staff perspectives, the trueness of the model to deliver what we intended to, and key learnings. And then the parts that we're just kind of getting the data out now around the outcome parts around how we're successfully linking them and some of the health and well-being and family perspectives and the young person's perspectives. And we're hoping that we'll have it all sort of wrapped up and finished by next summer. This is a depiction of some of the components and where we're sitting, so you can see where we are in 2013. So we're phase 2 model fidelity, and then the outcomes pieces kind of come next. I'm going to just share a little bit of information around the first part, which was the process evaluation. So we had, there were semi-structured, open-ended interviews with a number of stakeholders, including lots of members of the team, but also people that were involved in the development of the model, some of our senior administrators that were part of our steering committee, physicians that were involved on both the pediatric side and the adult side. And for this part, we did have some additional short-term funding from the Toronto Central LIN, which is our regional health funding agency, through the GTA Rehab Network. So it's a little complicated. We did have a little bit of funding there to work on some of the initial perspective of were we going to be successful in rolling out this new model of service. The key findings of that first phase 1 process evaluation really kind of were filtered down in a very, very basic way. This is kind of the findings. So it was enablers to the development of the model were leadership, commitment from senior leadership within both organizations, a trust by those two organizations and the people involved, that there was the right kind of expertise and the right kind of vision towards ensuring the success of the program, a shared accountability around delivery of service and sustainability of the model, and compatibility. So that really came down to very similar visions and missions for the organizations, similar perspectives on service delivery and what should be happening for these young people. And also, it also would include our our geographic proximity as well as part of that compatibility. Barriers included some infrastructure challenges, so things like not being able to very easily access the charts at both centers. I'm just going to try to close another thing in the corner here to see if I can see more of my screen. Okay, there we go. Culture of practice, and that really looked at sort of a pediatric culture, which is often a very caring and close-knit community that does a lot of looking after, and really pushing with this model towards one of that shared management, where you're sharing knowledge and sharing expertise and preparing the young person for to take on more responsibility. A structure of the practice, and again, that's somewhat a component of the infrastructure in the different organizations and what could be accommodated and feasible within the different structures, and financial resources, which means how big can we make the team, and how those financial restrictions are going to end up influencing the kind of service delivery that you offer. So just really quickly, the enablers were critical components, obviously, of a successful partnership. When they looked at the barriers, it really, it wasn't about the conceptual framework or the design of the model, but it really comes down to operationalizing your model and looking at what you're going to come up against in terms of where you are or what kind of space you have, the kind of financing you have to develop a team, those kinds of things. The mitigators were the commitment from the organization, and there was a lot around the commitment to having people work in both sites. That was something that people felt was a mitigator of some of the barriers. And there was early indicators in that part of the study around having some success, people feeling that it really was an important service and was doing what it was intended to do. We do have a few publications out of the LET study, that also things that have already been published, and some pieces that are in publication right now. And I'm happy to share this presentation following today's meeting if anyone's interested in these, so don't feel like you have to write them down. So I just wanted to briefly talk about some of what we think have been our successes, some of the challenges with developing a model of transition services. Certainly, there's been no shortage of people interested in being a part of it. We've got, I think, well over 350 young adults with cerebral palsy and acquired brain injury have now been transitioned from Holland-Dorothy to Toronto Rehab, and that's just since 2007. When we've done surveys, we do telephone surveys annually, 100% of those that have been involved would say that they would recommend lifespan to peers. And we've tried to really look at changing our model through using group interventions to be able to address the needs that we're seeing as common to a lot of our young adult clients. And we've also been successful in receiving some foundation support, actually from one of our young adult clients and their family, and they supported us with some money to allow us to hire an additional facilitator for time, as well as for some really nice renovations. A room at Toronto Rehab, so it's not quite done yet, but we're working on it. Some of our challenges certainly have been in terms of that same growth. When you're looking at the same team that we started with in 2007, it really changes how you're going to deliver services. So we've had to use groups, and we've had to look at becoming increasingly consultative in our service delivery. And with that comes, it behooves us to know a lot more about the services that are available in the community and be linking our clients with those services as often as possible. Some of the other challenges that have been identified are around the funding and access changes that occur as people are transitioning to adult services. So there's some changes in access to things like respite services. There's changes to access to some supports at home. And some of the funding opportunities that were available when we were younger are not as easy to access. So some of those are big challenges. Some of the determination of capacity and substitute decision makers is something that we've definitely identified as something that often comes up, and we're trying to address it earlier in pediatric care. Oftentimes, if a parent of someone with a significant disability is feeling some of their ability to care and be involved in care becomes more limited when their child is 18 and they're being asked, are you the substitute decision maker, and has a capacity evaluation been conducted? And we just want to make sure that we're supporting families through that process as well. Another challenge we have, and even though we're part of a very large acute care organization at UHN, is difficulty accessing adult specialists. So you can have, pediatric specialists for many, many years, and adult specialists tend to focus more on specific conditions or body parts as opposed to being more generalist, and often don't know a lot about, particularly something like cerebral palsy. So accessing adult specialists in a timely way and having a collaborative model of care has been a challenge. One of the other things we find with our population is we've had a relatively high no-show and cancellation rate, and that's both in our pediatric service as well as our adult service, and that's something that we've tried to address through a number of different ways. So some of the things that as we're growing up a little bit, is thinking about how do we sustain our service. So as we continue to add 60 to 80 new clients every year, how are we going to make sure that we can continue to provide access to the service? So some of the things that we're focusing on are our community capacity building, which I mentioned before, and alternative models of service delivery, such as using groups and identifying partners. We're also looking at increasing the capacity in our primary care providers, so really looking at how we can support primary care providers to do more care and become a greater support for our clients, as opposed to feeling that they need to come to us, and looking at how we can also review our model and use quality improvement methodologies to improve efficiency. And I'll talk a little bit in a minute, but one of the other things we really have to do is look at, what are the key components of a transition model of care that we should be looking to provide for our young adult clients and their families, so that we can move them on as independent users of the adult healthcare system, and then increase our access, for our ability to allow access for younger people. In terms of applicability to other populations, I think the model is one that can be fairly general. It could be there's a lot of applicability, I think, for other populations. It's got it's a holistic approach with an interdisciplinary team, and it's really looking at not just issues of persons with cerebral palsy or acquired brain injury, but really any, it could be any chronic disability that's acquired or congenital. We are right now, I'm working with a group at home where he's working with the TC Lynn and in partnership with Ann Johnson Health Station to develop a similar model, or a model based on similar principles for young people with spina bifida. So I think that a key question is, as our model continues to evolve, and I would hope maybe some of our colleagues from all over Canada can help to inform this, is when are we done with sort of this transition model? So we want to support the philosophical underpinnings of the chronic care model, but we also need to make sure that we are enabling access for young adults as they age out of the pediatric system. So what are sort of the key components of a transition program or model that will help to build capacity in our young adult clients and their families to make it so that we can that they feel like they're independent, competent users of the adult healthcare system and don't necessarily need a specialized transition program in the long term. So that's kind of where we're at now, and I will open it up to questions or comments from the audience.
Thank you, Joanna. Joanna, that was absolutely excellent to hear about a program that I think we've all heard bits and pieces of, but not sort of in its entirety. Given just sort of the time, maybe we can spend just about 5 minutes or so on questions, if there are from the group, and then we can make sure we save about 10 minutes for Elaine to speak and just to talk a little bit about what's coming up. Is that okay with everybody?
Mm-hmm. Sure.
Why don't I open it up? If there aren't any questions right away, I have one that I'd like to start with, if that's okay with you. Joanne, you identified the culture of practice as a barrier, but this project has been around for quite some time now. Have you noticed any shifts or do you have any tips for people at large in terms of changing that from a barrier to an enabler?
So I think, and when I said the culture of practice, that would be on both the adult side and the pediatric side, and I do think we've seen a shift, and that may be partly a local shift because we've got a model of service and people who are working on both sides and all talking about the same things. But I think even more generally, there is a bit of a shift system-wide around towards that sort of philosophy of chronic management disability, health sort of prevention, health promotion. All those things are often keywords in the development of any program of service in healthcare nowadays. So I think some of the language that was a little more foreign in 2005-06 when we were developing the model is more common now. So I think some of that, there has been a shift in that practice, and certainly locally within our two organizations, there is a shift for sure in terms of an emphasis on preparing young people to be independent and grow up ready. So we've got those growing up ready frameworks all over the organization. I think it's certainly embedded more into the culture of practice at Hollenbergie than it was previously. And also on the adult side, sort of recognizing that we have a role not just with young adults transitioning from pediatric care, but also young adult clients accessing health services or health care at any, for any reason, whether it be rehab or acute care, and recognizing the distinct needs that group has with respect to health service delivery. So I do think some of it has happened already.
I had a question in relation to one of the first slides you showed was some brochure material where you talk about the different ages across the top, but your picture of the person doesn't change in age. And it just immediately put my mind that you weren't really addressing the actual youth, the young, 16, 18-year-old, and creating material that I guess was respecting of their age. And then I was just sensitive over the next couple of slides to that continued, what seemed to me, like in Toronto, you use, sick kids and kids rehabilitation center, and I just wonder whether there is enough support actually within the kids framework of care to really support kids who are 14, 15, 16, 17, who you are still really responsible for, or whether this seems to be more focused on the pediatric, 0 through 10 or 12 years old, and that drop in care actually starts so early, way back at, maybe 13 or 14 years old, where already there's an awkwardness of the kid's institution not supporting that young teen moving into youth before even getting to the transition of going to adult care.
You make some really interesting points there. I certainly think a lot of us notice the language we use when we have kids in the names of organizations, and whether young people who are 12 to 18 consider themselves kids or not. When I look at the timetable for growing up, you're right, it's the same child, and obviously they did it all when she was the same age, so it doesn't really reflect their that sort of the teenage years in the picture, and that's the first time anyone said that, so that's very interesting.
The age of the child didn't change, but you're talking about all the way up to, did it go to 21 years old or something? 17?
Yeah, major life changes, sure.
And you're still showing a 6-year-old.
So I think that's something, I think it's one of those things where it's interesting, because I recently was involved with the project, and we had a poster that went up to help inform people, and it had a teenage boy, so probably closer to 18 in the picture. And we took it to the Family Advisory Committee. A lot of the parents that were involved on that committee felt that it didn't reflect a child, and they felt so that it didn't match sort of what their perspective was on kids rehab. So yet he was definitely a client of our organization, and we have a fairly large number of young adult clients at home living. So I think depending on where you are, there could be that sort of a mismatch of fit, where you go into a waiting area and they have those tiny wheelchairs and the marble game, or do we have things that are more age appropriate? I think that's something for me to consider. And then in our adult rehab center, some of the feedback that we've definitely had from our interviews with the young adults is that the adult center to them seems so much more depressing than the pediatric center, which is really bright and sunny. And this is coming from our young adults, so maybe there's something to be learned on both sides, how to make it more age appropriate for that particular age group.
I guess I just feel like there needs to be a caution with the use of the language of transition, is that it doesn't become almost a scapegoat to them not being this and not being that. And if there was, as long as there is always a full respect for them being a teen, and it's okay to be a teen, like that's a fully qualified place in your life. It's not that you're not a child and you're not an adult, because I think that there's all kinds of permission for things then to not be really 100%, because you're not really seen as 100%. And I just caution, this transition thing. I wouldn't myself, if I was a patient, like to hear that for years and years, that I'm in transition. I think that it's actually disempowering to the patient that they are fully fantastically a teenager and fully fantastically a youth, and one day fully fantastically an adult, and each of those chapters in one's life has a dignity to it and of 100% kind of fullness to it. I just, as I introduced myself at the beginning of the meeting, I've gone through 19 years of taking, a newborn baby, and then to his death ultimately.
Mm-hmm.
And
I think. Well, thank you for sharing as well. But I wonder if there's, when we're looking at services that are helping children to develop skills that will make them successful teens or young adults, and I totally agree with you. I do think we want to empower all ages. What kinds of language should we use then? Are there different terminology that we should be trying to include?
Well, I think that if transition was secondary in its grouping and definition of the patient, like they're a teen in transition or a youth in transition, rather than, that they don't, rather than them not quite fitting into either of the two really defined institutional cares. Like, it's almost like the pediatric thing, it's cuter and it's friendlier and it's more fun. And then all of a sudden, what I experienced with my son, and I know that you're definitely, working at mitigating the error of expecting all of a sudden at 18 years old a child to be relied upon to carry their side of the care picture. And that was kind of the case with my son, that there was an expectation that now he was 18 and going to his first couple of appointments at the adult hospital, that I no longer was really relevant as the parent. And I think for them to be given a full kind of class, it's almost like a first-class citizen kind of sense, that they are youth and they are fully allowed to be youth. But for it to be an expectation for them to kind of carry the load of responsibility is really damaging to the trust that's occurred already during the pediatric time with the parent.
Sorry, I'm just going to interrupt. It's Trish speaking here, partly in the interest of time, and thank you very much, Lucinda, for sharing not just your experience, but your clearly your perspective on some of the semantics and the language we're using. As you sort of figured out, I'm sure everybody else in the call is sort of rethinking those words and about really putting the person first. I think what we're all faced with is the fact that we do have two very different systems, and in between those systems is a period of transitions. It's the best label we've got so far, but it isn't about the person being a transition. It's about the process being the transition. So,
right.
Joanne, thanks again for that presentation. If you are willing to share the slides or sharing certainly at least the publications and the references, I think that would be really great for the rest of us. I believe Elaine may be on the line, or Lisa may be on the line, just to talk a little bit about our the CAPC conference on October 23rd and the workshop planned for the evening on the Wednesday.